Good afternoon all. In this session we'll cover ACLS in adult, that is advanced cardiovascular life support. ACLS is continuation of basic life support and it is systemic approach to assessment and management of cardiopulmonary emergencies. Resuscitation efforts aimed at restoring spontaneous circulation and retaining intact neurologic functions. ACLS guidelines were first published in 1974 by the American Heart Association and they are updated every 5 years. Latest update is in 2020. This is chain of survival. The first one is adult in hospital cardiac arrest chain of survival and the second one is adult out of hospital cardiac arrest chain of survival. These we have already been discussed in BLS. Just to revise, the chain of survival is a metamorph used to organize and describe the integrated set of time-sensitive, coordinated actions necessary to increase survival. So these are the 6 links and sixth link is the recent link has been added in 2020 guidelines. So in hospital chain of survival, the first step is early recognition and prevention. Second is activation of emergency response system, then high quality CPR, early defibrillation, post cardiac arrest care, including critical care interventions and targeted temperature management. And recovery, it includes the effective support of physical, cognitive, emotional and family needs. In out of hospital cardiac arrest chain of survival, the first step is different, that is activation of EMS. Then high quality CPR, early defibrillation, advanced resuscitation, post cardiac arrest care and recovery. So this is systematic approach algorithm. For optimal care, healthcare provider use a systematic approach to assess and treat arrest and acutely ill or injured patient. Following systematic approaches are initial assessment, which constitute visualization and scene safety, BLS assessment, primary assessment, ABCDE and secondary assessment, with the focused history and H&Ts. So after confirming the scene safety, provider visually check while approaching the patient whether the patient is unconscious or conscious. When the patient is unconscious, we have to do BLS assessment, that is check responsiveness, activate EMS and get defibrillator, check breathing and pulse. If there is no pulse and breathing, we have to immediately start high quality CPR. When the pulse is present, one breath given every 6 seconds and do primary assessment. When the patient appears to be conscious, we have to go for primary assessment. Now, what is the primary assessment? So, primary assessment constitute A, B, C, D, E. That is airway, breathing, circulation, disability, and exposure. In disability, we can check for neurological function, quickly assess for responsiveness, level of consciousness, and pupil dilatation. We can do AVPU scoring, that is alert, voice, painful, unresponsiveness. In exposure, remove clothing to perform a physical examination. We can look for obvious signs of trauma, bleeding, burn. In secondary assessment, involve the differential diagnosis, include a focused medical history, and searching for the reversible causes of cardiac arrest, which are H and T's, which we'll discuss later on. So, what are the 5H and 5T? These are the reversible causes of cardiac arrest. These are hypovolemia, hypoxia, hydrogen ion, acidosis, hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, thrombosis, pulmonary or coronary. So this is the adult cardiac arrest algorithm, ACLS algorithm. So whenever we see the cardiac arrest victim, with the continuation of BLS, give oxygen, attach monitor and defibrillator, and we have to see whether the rhythm is shockable or non-shockable. When the rhythm is non-shockable, that is the rhythm is asystole or PEA. So in that case, we have to do high quality CPR The characteristics are push hard at least 2 inches, that is 5 centimeter, and fast, that is 100 to 120 per minute, and allow complete chest recoil. Minimize interruptions in chest compression, avoid excessive ventilation, change compressor every 2 minutes or sooner if fatigued. The compression ventilation ratio should be 30:2 if no advanced airway. And quantitative waveform capnography is now has a very important role. If end tidal CO2 is low or decreasing, so we have to reassess CPR quality. So if the rhythm is shockable, that is VF and pulseless VT, then immediately we have to give shock. So shock energy for defibrillation, if it is biphasic, manufacturer recommendation, example, initial dose of 120 to 200 joule is chosen. If unknown, use maximum available. Second and subsequent doses should be equivalent and higher dose may be considered. If there is a monophasic defibrillator, then 360 joule should be considered. So after giving shock, immediately resume CPR for 2 minutes. And simultaneously, we have to secure IV or intraosseous access. Again, after 2 minutes, we have to check for rhythm, whether it is shockable and non-shockable. When the rhythm is shockable, give shock and immediately start CPR for 2 minutes. At this time, we can consider epinephrine every 3 to 5 minutes and consider advanced airway capnography. Again, after 2 minutes, we have to check for rhythm, whether it is shockable or non-shockable. If the rhythm is shockable, give shock, immediately start CPR for 2 minutes, and at this step, we can consider anti-arrhythmic like amiodarone or lignocaine. And simultaneously, here we also see the reversible causes of cardiac arrest, which we have already been discussed. In the drug therapy, the epinephrine can be given intravenous or intraosseous route. The dose is 1 milligram every 3 to 5 minutes. Amiodarone, the first dose is 300 mg bolus, second is 150 mg. Or lignocaine can be given first dose 1 to 1.5 milligram per kg, second 0.5 to 0.75 milligram per kg can be given. So for non-shockable rhythm, that is asystole and PEA, we should use epinephrine as soon as possible. Continue CPR for 2 minutes, and simultaneously we have to secure IV or intraosseous access. Epinephrine should be given every 3 to 5 minutes. Consider advanced airway and capnography. And after 2 minutes of CPR, again the rhythm should be checked whether it is shockable and non-shockable. If it is non-shockable, continue CPR for 2 minutes and treat reversible causes of arrest. Anytime when the rhythm becomes shockable, we have to follow the left side of the algorithm. For advanced airway, endotracheal intubation or supraglottic advanced airway can be considered. Waveform capnography or capnometry to confirm and monitor ET tube placement. Once advanced airway is in place, give one breath every 6 seconds, that is 10 breaths per minute with continuous chest compressions. So when we continue CPR till step 11, we have to analyze the rhythm, whether the rhythm is shockable or non-shockable. When the rhythm is shockable, go to step 5 or 7. When the rhythm is non-shockable, go to step 12. That is, if no sign of return of spontaneous circulation, go to step 10 or 11. If there is a return of spontaneous circulation, go to post cardiac arrest care. Consider appropriateness of continued resuscitation. So what are the characteristics of return of spontaneous circulation? Pulse, blood pressure will be present. Abrupt sustained increase in end tidal CO2, that is more than or equal to 40 millimeter of mercury. Spontaneous arterial pressure wave with intra-arterial monitoring. So this is cardiac arrest in pregnancy in hospital ACLS algorithm. So first step is continue BLS or ACLS. We should provide high quality CPR, defibrillation when indicated, Other ACLS intervention like epinephrine should be considered. Assemble maternal cardiac arrest team. Consider etiology of arrest. And we have divided into, that is, maternal intervention and obstetric intervention. In maternal intervention, perform airway management, administer 100% oxygen, avoid excessive ventilation, place IV above diaphragm. If patient is receiving IV magnesium, stop and give calcium chloride or gluconate. Continue BLS or ACLS by giving high quality CPR, defibrillation when indicated, and other ACLS intervention like epinephrine. In obstetric intervention, provide continuous lateral uterine displacement, detach fetal monitors, prepare for perimortem cesarean delivery. Perform perimortem cesarean delivery if there is no return of spontaneous circulation within 5 minutes. Consider immediate perimortem cesarean delivery and neonate team to receive the neonate. In maternal cardiac arrest, team planning should be done in collaboration with the obstetrics, neonatal emergency, anesthesiology, intensive care, and cardiac arrest services. Priority for pregnant women in cardiac arrest should include provision of high quality CPR and relief of aortocaval compression with the lateral uterine displacement. The goal of perimortem cesarean delivery is to improve maternal and fetal outcome. Ideally, perform perimortem cesarean delivery in 5 minutes, depending on provider resource and skill sets. And what are the concerns for advanced airway in pregnancy? In pregnancy, difficult airway is common. Use the most experienced provider. Provide endotracheal intubation or supraglottic advanced airway. Perform waveform capnography or capnometry to confirm and monitor ET tube placement. Once advanced airway is in place, give one breath every 6 seconds, that is 10 breaths per minute with continuous chest compression. And we have to look for potential etiology of maternal cardiac arrest. These are anesthetic complications, bleeding, cardiovascular, drugs, embolic, fever, general non-obstetric causes of cardiac arrest, 5 NTs which we have already discussed, and hypertension. So this is the opioid associated emergency for healthcare provider algorithm. In first step, if there is a suspected opioid poisoning, check for responsiveness, shout for nearby help, activate EMS and get naloxone and AED if available. Second step is the person breathing normally? If yes, prevent deterioration, tap and shout, open the airway and reposition, consider naloxone and transport to the hospital. Fourth step is ongoing assessment of responsiveness and breathing and go to step 1. If the breathing is not normal, then we have to look for, does the person has pulse, assess for less than or equal to 10 seconds. If pulse is present, then we have only support ventilation. Open the airway, reposition, provide rescue breathing or bag and mask device, give naloxone. If there is no pulse, then we have to immediately start CPR, use AED, consider naloxone when available, and refer to BLS cardiac arrest algorithm. This is the adult Brady cardiac algorithm. First step is assess appropriateness for clinical condition. Heart rate is typically less than 50 per minute if bradyarrhythmia is there. Second step is identify and treat the underlying cause, maintain patent airway, assist breathing as necessary, give oxygen if hypoxemic, cardiac monitor to identify the rhythm, monitor blood pressure and oximetry. IV access should be secured to LED ECG if available, but don't delay the therapy. Consider possible hypoxic and toxicologic causes, which can be myocardial ischemia, infarction, drugs like calcium channel blocker, beta blocker, digoxin, hypoxia, electrolyte abnormality like hyperkalemia, all can cause bradycardia. If bradyarrhythmia is persistent and causing hypotension, acute alter mental status, signs of shock, ischemic chest discomfort, acute heart failure, if no, then we have to just monitor and observe the patient. If yes, then give atropine in the dose of 1 milligram bolus and repeat every 3 to 5 minutes, maximum 3 mg can be given. If atropine is ineffective, transcutaneous pacing can be considered and or dopamine infusion in a dose of infusion rate of 5 to 20 mics per kg per minute. Titrate to the patient's response and taper slowly. Or epinephrine infusion in a dose of 2 to 10 microgram per minute infusion. Titrate to the patient response. The next step is consider expert consultation, and we should consider for transvenous pacing. So this is the algorithm of adult tachycardia with pulse. First, assess the appropriateness for clinical condition. In tachyarrhythmia, heart rate is typically more than or equal to 150 per minute. So first step is to identify and treat underlying cause. Maintain patent airway, assist breathing as necessary. Oxygen should be given if hypoxemic. Cardiac monitor to identify rhythm. Monitor blood pressure and oximetry. IV access should be secured. 2-lead ECG if available. If persistent tachyarrhythmia causing hypotension, acute altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. If yes, then synchronized cardioversion should be considered. Consider sedation. If regular narrow complex, consider adenosine. For synchronized cardioversion, refer to your specific device recommended energy level to maximize first shock success. Adenosine should be given in the IV dose. First dose 6 mg rapid IV flush followed with NS flush. Second dose 12 mg if required. If these signs symptoms not present, then we have to see the QRS complex. Wide QRS complex of more than or equal to 0.12 second. If yes, then consider adenosine only if regular and monomorphic. Antiarrhythmic infusion can be considered an expert consultation. In antiarrhythmic infusion for stable wide QRS tachycardia, propanamide IV dose should be used in the dose of 20 to 50 mg per minute until arrhythmia suppressed. Hypotension ensues. QRS duration increase more than 50% or maximum dose 70 mg per kg given. Maintenance infusion in a dose of 1 to 4 mg per minute. Avoid if prolonged QT or CHF. If refractory, then consider underlying cause. Need to increase energy level for next cardioversion. Addition of antiarrhythmic drug and expert consultation. Antiarrhythmic drug next can be used amiodarone. First dose 150 mg over 10 minutes. Repeat as needed if VT occurs. Followed by the maintenance of infusion of 1 mg per minute for first 6 hours. If QRS interval is not wide, then vagal maneuver if regular, adenosine if regular, beta blocker or calcium channel blocker can be considered. Consider expert consultation. So sotalol IV can be used 100 mg 1.5 milligram per kg over 5 minutes. Avoid if prolonged QT. So this is adult post cardiac arrest care algorithm. When ROSC obtained, return of spontaneous circulation is obtained, then we have to manage airway. Early placement of endotracheal tube can be considered. Respiratory parameter, we can start 10 breaths per minute, and SpO2 should be maintained between 92 to 98% with PaCO2 35 to 45 millimeter of mercury. Manage hemodynamic parameter, systolic blood pressure of more than 90 millimeter of mercury and mean arterial pressure of more than 65 millimeter of mercury. obtain 12 lead ECG. This is initial stabilization phase. In initial stabilization phase, resuscitation is ongoing during the post-ROSC phase and many of these activity can occur concurrently. However, if prioritization is necessary, follow these steps. Airway management with the waveform capnography or capnometry to confirm and monitor endotracheal tube placement. Manage respiratory parameter. Titrate FiO2 for maintaining saturation between 90 to 98%. Start 10 breaths per minute and titrate accordingly to maintain PaCO2 of 35 to 45 mm of mercury. Manage hemodynamic parameter. Administer crystalloid and or vasopressor or ionotrope for the goal of systolic blood pressure of more than 90 mm of mercury or mean arterial pressure of more than 65 mm of mercury. So consider for emergent cardiac intervention if ST elevation MI present, unstable cardiogenic shock, mechanical circulatory support required. If the patient follows command, if yes, if he is awake, other critical care management. If patient doesn't follow the command, he is comatose, then targeted temperature management, obtain brain CT, EEG monitoring, other critical care management, evaluate and treat rapidly reversible etiology, involve expert consultation for continued management. These constitute continued management and additional emergent activities. These evaluations should be done concurrently so that decision on targeted temperature management receive high priority as cardiac interventions. Emergent cardiac intervention, early evaluation of 12 lead ECG, consider hemodynamics for decision on cardiac intervention, targeted temperature management if patient is not following command, start TTM as soon as possible, begin at 32 to 36 degrees Celsius for 24 hours by using the cooling device with feedback loop. Other critical care management include continuously monitor core temperature, maintain normoxia, normocapnia, euglycemia, provide continuous or intermittent EEG monitoring, provide lung protective ventilation. So when to ACLS termination of resuscitation, look for arrest not witnessed, no bystander CPR, no return of spontaneous circulation before transport, no shock was delivered before transport. If all the criteria are present, consider termination of resuscitation. If any criteria is missing, continue resuscitation and transport. This is the multimodal approach to neuroprognostication. Why neuroprognostication is important? Because hypoxic ischemic brain injury is the leading cause of morbidity and mortality in survivors of out of hospital cardiac arrest. Neuroprognostication relies on interpreting the result of diagnostic tests and correlating those results with the outcome. So various tests can be used like CT head, MRI, electrophysiological tests like somatosensory evoked potential, EEG, and serum biomarker like serum NSE, and various clinical tests can be used for neuroprognostication. In patients who remain comatose after cardiac arrest, neuroprognostication should involve a multimodal approach and not to be based on a single finding. And it is reasonable to perform multimodal neuroprognostication at a minimum of 72 hours after normothermia, though individual prognostic tests may be obtained earlier than this. So in exam, you can be asked what is new in 2020 AHA ACLS guidelines. In chain of survival, the sixth link has been added, which is recovery, re-emphasis on early initiation of CPR, enhanced algorithm and visual aids, emphasis on early epinephrine in asystole and PEA, IV intravenous access preferred over intraosseous access, return of spontaneous circulation, emphasis on optimum oxygenation and blood pressure. In recovery, support and assessment of cognitive, physical, and psychological needs. Neuroprognostication diagrams has been added. Debriefing of hospital and lay rescuers. New algorithms of pregnancy and opioid-associated emergency has been added. You should also know the difference between 2015 and 2020 ACLS guidelines. Like in ventilation in 2015, one breath every 5 to 6 seconds with bag and mask, and one breath every 6 seconds with advanced airway. While in 2020, one breath every 6 seconds with or without advanced airway. In bradycardia, atropine was given 0.5 milligram and dopamine 2 to 20 mics per kg per minute in 2015 guideline, and in 2020, atropine 1 milligram and dopamine of 5 to 20 mics per kg per minute. Post cardiac arrest care titrate oxygen saturation of 94 or more. But in 2020 guideline titrate oxygen saturation 92 to 98%. Chain of survival, 5 links were there in 2015 and 6 link has been added in 2020. IV and IO access both are equal, but in 2020 IV access is preferred over intraosseous access. Few words about IRC. CCLS. CCLS is Comprehensive Cardiopulmonary Life Support, given by IRC, Indian Resuscitation Council. The guidelines were developed considering the need for a universally acceptable practice guideline for India. IRC became an official member of European Resuscitation Council in 2022. In CCLS, we have 5 links. First is early recognition and management of pre-arrest condition, early recognition and activation of code blue, early high quality CPR, early defibrillation, and early comprehensive life support and post resuscitation care. This is the CCLS algorithm given by the IRC. It is mostly same as ACLS guideline with a few differences which we'll discuss later on. What are the differences between ACLS and CCLS? In ACLS, the chest temperature rate is 100 to 120 per minute, and in CCLS, it is 120 per minute. One breath given every 6 seconds in ACLS, while in CCLS, one breath every 5 seconds. For venous access, IV intravenous preferred over intraosseous in ACLS, while in CCLS, 3 attempts for intravenous access, otherwise intraosseous. In post-cardiac arrest care, saturation target should be 92 to 98% in ACLS, while in CCLS it is 95% or more. Temperature target is 32 to 36 degree Celsius in ACLS, and it is in CCLS not more than 36 degree. Adult chain of survival, there is 6 links in ACLS, while in CCLS the 5 core links are there.
Unmute, sir, please.
Okay, so we had a
Is the
very
presentation
lucid...
visible?
Yeah, to me it is.
So can I start with arrhythmias in ICU?
Yeah, please, Dr. Kailash, I invite you to start your arrhythmias in ICU.
The presentation is visible to everyone, no?
Yeah, I can see.
Yeah. So Dr. Sangeeta had talked about the